So, good morning and a warm welcome to all the dignitaries present here. I'm Sreushi from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as the digital partner for this event hosted by the Indian Society of Prenatal Diagnosis and Therapy, and the focus of today's session is ISPAT webinar but defects. So let's begin today's session, for which I would like to invite the President of ISPAT, Dr. Saurabh Danisa. Sir, we would like to hear some words from you. Over to you, sir.
Yes. Thank you, Clarinet, for helping us do this webinar. And it's always been a pleasure to work with Clarinet. And today we have designed a special webinar in because today is International Birth Defects Day. And I'm sure Manjeet, she would be joining soon, and she will tell us more about what the means by International Birth Defects Day. And but I will give you a small brief about what ISPAT is. So ISPAT is the Indian Society for Prenatal Diagnosis and Therapy, which was formed way back in 1990. And the whole idea of ISPAT was to work towards early detection of anomalies and problems and how to manage them and prevent them. And that was the whole focus of ISPAT. And the advantage of ISPAT is that it's a multidisciplinary organization where we don't have only obstetricians or pediatricians or something, but we have a host of different experts. That is pediatricians, gynecologists, pediatric surgeons. Then we have scientists, we have biochemists, we have lab medicine specialists, we have genetic counselors. So together, when all these multidisciplinary clinicians are present, then we have more understanding of the problem and we are in a better position to really solve those issues which are coming up in India. So, and I'm very thankful to Niharika Malhotra and Niharika Tyagi for taking this head on and conducting this two panel discussions. The two panels, one is going to be what we do before delivery, and one is going to be what is we do after delivery. And together we will talk about how we can prevent, and if we can't prevent, how do we really manage this birth disorders. So, thank you, Niharika, for taking this, and over to you, Manjeet.
Thank you so much, sir. Thank you so much for your kind and comprehensive talk. So now I would like to invite Dr. Manjit Mehta ma'am to take over the session. She's the Secretary of ISPAT. Over to you, ma'am.
Thank you. Hello, everybody. Good morning. It's very heartening to see so many people coming together, and the awareness of World Birth Defects Day is increasing so much. So, as you are all aware that the 3rd of March is observed as a World Birth Defects Day across the globe. And that is the reason why we are having this webinar. Birth defects affect infants regardless of their birthplace, race, or ethnicity. They are a leading cause of death for infants and younger children globally. Those who survive and live with these conditions are at a risk of lifelong, some increased disabilities. So it's important that people who are in this field and allied fields unite together, and organizations who work in the field of birth defects. And that is precisely the role of ISPAT over here. You know, we would like to mobilize the resources and commitment to improve birth defect surveillance, research, prevention, cure. And once again, thank you all for joining us here. And let us get on with these invigorating discussions that we have planned. Thank you. We could start with the panel discussions.
So before we started the panel discussion, Niharika, if we can,
Okay, we have this.
somebody from Clarinet can do
Clarinet
the
has.
inauguration video.
Yeah, sure, sir.
Society for Prenatal Diagnosis and Therapy. is one of the oldest Indian organizations to work in the space of preventing birth defects. Our members are obstetricians, gynecologists, pediatric surgeons, geneticists, biochemists, and all from the various fields of science to help in preventing birth defects. Birth defects is not the only thing which can be seen, but there are a lot of birth defects which cannot be seen. And for that, newborn screening is an important tool. We advise you to start newborn screening and offer newborn screening to all the babies who are born in your setup. And to all the parents, kindly take a newborn screening test for your child.
World Birth Defects Day is observed on March 3rd annually, raising awareness about birth defects and their impact on individuals and their families worldwide. In India, common birth defects include neural tube defects such as spina bifida, congenital heart defects, cleft lip and palate, Down syndrome, and thalassemia.
Birth defects are structural or functional abnormalities which are present at birth. They can occur during the prenatal development, that's before a child is born, and may appear to affect various parts of the body such as organs, bones, or chromosomes. These abnormalities can result from either genetic factors or environmental factors or a combination of both.
देखिए हर बच्चे में कोई ना कोई नुक्स या डिफेक्ट पैदा हो सकता है. All children are exposed and at risk of birth defects. So kindly get your screening done properly in pregnancy in the first trimester by the biochemical markers and by NT&B scan, and in the second trimester by the fetal anomaly scan.
Consanguinity is the marriage between the close relatives. In India, it is the cousin marriage. The chances of autosomal recessive genetic condition increases with the consanguinity. Based on your family history and personal medical history, you can do the carrier testing and you can avoid a birth of a genetically abnormal baby.
And in this context, we must provide at least 3 scans in pregnancy: first trimester nuchal scan, second trimester anomaly screening, and third trimester growth and Doppler, so that we can detect all birth defects to the maximum possible.
It's important to note that 20% of these congenital birth defects can have a genetic etiology. Sharing a common ancestor like consanguinity or endogamy can lead to amplification of genetic mutations that can lead to autosomal recessive disorders. Comprehensive genetic testing allows us to look into the possibility of such disorders and helps the family to take a knowledgeable decision.
After we have got a fair degree of control over infections, birth defects have become an important cause of perinatal mortality and morbidity. Timely detection, proper workup, genetic testing, and a logical care to that pregnancy can lead to a very good outcome even in cases of birth defects. The first trimester screening is the most important window where we can start detecting birth problems, because you can have a comprehensive evaluation of the fetal structure in the first trimester NT scan. There are also methods to do screening for chromosomal and genetic abnormalities in the first trimester.
About 27 million babies are born each year with various kinds of birth defects. Consanguinity, ethnicity, and family history also can cause added risk to this. It is possible to prevent most of the birth defects by offering at different stages of life, like preconception, premarital, prenatal, or even post-birth as newborn screening.
Don't miss the first trimester scan, which will also double up the screening, where many of the major congenital abnormalities for birth defects are incompatible and can be detected, and then we can pave a way forward for this pregnancy with the couple.
According to the recent estimates, the prevalence of birth defects in our country, India, is almost 6 to 8%. The incidence of birth defect varies on different factors like the region, the socioeconomic status, and even environmental factors. The risk of having an abnormal child or a child with birth defect actually increases with the increase in maternal age, because older women have a higher incidence of genetic mutations and chromosomal abnormalities.
Why does it happen? There are genetic reasons for it as well as environmental reasons like abnormal drug use, alcohol use, and smoking during pregnancy. So what expectant mothers can do, they can avoid alcohol, smoking, illicit drug use, follow a healthy lifestyle, and follow medications and management as told by their physicians.
By screening between 11 and 14 weeks of pregnancy by doing an ultrasound and biochemical markers, we can classify them as low risk and high risk. Those who are reported high risk deserve invasive prenatal diagnosis. The procedures available are in the first trimester, that is between 11 and 14 weeks. It is the chorionic villus sampling where we get in some tissue which is the future placenta. Same can be done if the patient comes little late, and that is amniocentesis between 16 and 20 weeks of pregnancy, where a fluid is tapped from the pregnancy sac, and these can be studied for complete karyotype of the baby, and you can come to know which baby is affected and which baby is normal.
With so many advances in genetic testing, birth defects can be detected at a very high accuracy at various stages. Career testing for the couples before they have planned a pregnancy, prenatal testing for the lady once she is pregnant, and newborn screening for the baby as soon as they are ready.
Regular screening and antenatal checkups will actually help us in preventing birth defects. Let us join hands and bring this incidence down in our country.
Together, let's prevent birth defects, detect birth defects, and treat the birth defects.
Thank you so much.
Thank you, Shriyanshi.
Thank you. So, should I play the newsletter video now?
Yeah, so just to give a context, this video we have released, and this has been, it's a compilation of the thoughts of a lot of our leading KOLs of the country from the various specialties that are, part of this entire ecosystem of preventing birth defects. This will be available on YouTube, and the link is available on our ISPAT website. Going to the next one, we have also launched our ISPAT newsletter, which we would be, having regular copies being released, regular editions being released. And this is the first one in the series. And we bring to you case studies, we bring to you guidelines, we bring to you information. If you would like any other points to be covered in successive newsletters, your inputs are welcome. So could we have a look at the first issue that is being launched today? Shriyanshi?
Yes, ma'am. I'm just playing.
The persons who have put in all the efforts behind this, Dr. Veronica Arora from Delhi, Dr. Niharika Malhotra, Dr. Dhanlakshmi Shetty, and we have an entire team of people who have, brought this whole thing into shape. Looking forward for articles from all of you all also for the future editions. So these are the two launches that we have done on this landmark day. And now today in this session, we bring to you really interesting two panel discussions. The first one is on the prenatal aspects, and the second one will be post-delivery, the neonatal aspects. So we could start with the first panel, Shriyanti.
Sure, ma'am. So for the
Yeah,
yes,
and
yes, ma'am.
just before we just start, one word, and I would like to thank Manjeet for being a silent worker behind the scenes, coordinating with everybody here around here and getting this done on the right date at the right time and putting in a lot of efforts, forcing me into not canceling any events or postponing any events. And thank you, Manjeet, for all your help.
Thank you.
Thank you so much, sir. So now for the panel discussion, I would like to invite Dr. Niharika Malhotra ma'am and Dr. Shahla Jamal ma'am. Please, ma'am, kindly proceed.
Thank you, everyone, and heartiest congratulations to ISPAT for celebrating the World Birth Defect Day so beautifully today with multiple programs all over. We are going to begin with our panel discussion on genetic testing in OBGYN and how to go about it. And me with Dr. Shaila Jamal will be coordinating this session today. As we know, there
So,
are
sorry, Niharika, as a committee member, you could please introduce yourself as well as your co-moderator. I'm sorry for that.
That's all right, ma'am. And I'm Dr. Niharika Malhotra from Rainbow IVF Agra. I'm an infertility specialist. And along with me is Dr. Shaila Jamal, a very senior obstetrician professor and also a very dear friend who's joining from Bareilly today, and we are going to be discussing genetic testing today. So as we all know that we are celebrating World Birth Defect Day, and human body is a very intricate machine that receives orders from the long string of chemicals called DNA. And there are labs now which can actually sequence this entire DNA and understand the human body. We are now in an era of prenatal testing, and it is our duty as a practitioner to know about all kinds of prenatal testing so we can offer the best to our patients. So, today I would like to invite our esteemed panelist for this session, Dr. Naren Malhotra, Senior OBGYN and Fetal Medicine Specialist from Agra, Dr. Arup Majhi, who is very, very senior president of ISOPAP Society, Dr. Vivek Kashyap, expert radiologist from Delhi, Dr. Sita Pal, senior fetal medicine specialist from Kolkata, Dr. Prerna Keshan, infertility specialist from Tinsukia, Dr. Indranil Datta, high risk pregnancy obstetrician from Calcutta, and Mrs. Lakshita Chauhan, our genetic counselor. As you know, we have tried to involve all specialities who are there to offer any form of genetic testing to our patients in today's panel. And now I would invite Dr. Shaila Jamal to take over further and begin this panel. Dr. Shaila?
Thank you so much, Dr. Niharika, and thank you so much to the entire office of ISPAT and the team behind developing this special this special webinar. Actually, I'm not able to share my screen. So, is it visible?
Yes,
Yes.
ma'am, your screen is visible.
So, Dr. Niharika, thank you for giving me this opportunity.
You could go into the presentation mode.
Yes. So, my first question to Arup Maji sir. Sir, very good morning. Greetings from Bareilly and entire North India to you. So, what are the genetic testings you know about and the common ones which you are using in your practice?
Shaila, your screen is not moving.
Oh, it was on. Thank you. Now I'm audible. Am I audible now?
You
Yes,
need to
sir.
go
Yes, sir.
to
Yes.
you need to go into presentation mode.
Make it full screen, Shaila.
No, this is not full screen. Present, yeah.
No, we can't see the presentation. Sharing it again.
Dr. Niharika, can you please share the screen from your side? I think there is some problem.
Is it okay?
So, Arup sir,
Am I
we are
audible
seeing
now?
that.
Am
Yes,
I
sir, you
audible?
are. Yes, sir.
Audible. So thank you, Dr. Niharika. Thank you, the President, Dr. Saurabh, and thank you, Secretary Manjit, and all the organizer, esteemed organization ISPAT, for inviting me. There's a very new topics because the birth defect is a problem and going increase day by day. So my question was, what are the different types of testing or genetic testing is that? I think a question to me. So there are so many testings has come, and first of all, what will you do? That is the case of the screening test. Actually, the screening test is done. Usually the combined test is a very common dual marker. It is 11 to 13 weeks, and dual marker means the biochemical test and also combining with the ultrasound. And second is the NIPS, NIPS test, that is a non-invasive test. It is also used till though high sensitivity, but also used with the screening test. And other important tests that we know, actually the karyotyping is commonly done, and another is the FISH test, and the PCR test, polymerase chain reaction, and most useful test, to some extent expensive, that is the microarray analysis, the CMA test, chromosomal microanalysis, and other very expensive test, that is the whole exome and sequencing and whole genome sequencing. And the karyotyping only is limited to the almost in the to detect whether it is the aneuploidy and polyploidy, and FISH other than the chromosomal anomaly, the particular chromosomal anomaly, whether there is a suspected uh, deletion or addition. And CMA test is the most 100 times most uh, sensitive test than all other tests. Is not only do the karyotyping, but also the micro deletions, and better than the FISH. And whole genome therapy, whole genome sequencing, actually the entire genome at most Peter-Swiss structural analysis have normal karyotype and normal shape. So that case is very important, is the whole genome sequencing. And whole exome sequencing is the analysis only for the DNA coding regions, and apparently 1.5% of the whole genome. So this is the common, not common, but this is the usual test available in the market. What we commonly do is the dual test and also the karyotyping, FISH, and sometimes the PCR, and lastly the microarray. FISH means the fluorescent in situ and hybridization. So these are all the tests can be done to detect the not all cases, but in the indicated cases. Thank you.
Thank you so much, sir. Thank you, sir, for giving us a comprehensive idea. Dr. Indranil, my question to you is, how do you choose in what abnormality or screening or diagnosis, what will you order?
See, first basic thing is we have to know about the history, because history taking is a basic. We have to take history about the past, any disorders. If suppose she is suffering from thalassemia, sickle cell disease, or any chromosomal disorder, even in the family. Suppose the patient comes with recurrent pregnancy loss, so asking a detailed history about past causes of if it fits into the causes of pregnancy loss, which is genetic in nature. So these are the patients we have to select case by case, like unexplained stillbirth. All those things will fit into the cases wherein we have to understand the genetic part of it. Now, when we choose the genetic part, there are two ways. One is the practical and one is the theoretical. The practical aspect, we all know that whatever the basic test we have in hand is a integrated testing, the karyotyping, all those things. We can do a karyotyping as early as 12 to 13 weeks if we can do chorionic villus sampling. If we suspect that something may be wrong with this current pregnancy only. But if the patient has come for preconceptual counseling, we can do lot of different tests like genetic sequencing. Now there are two basic things I want to add: this clinical exome sequence and this whole genome sequencing. I know it is more of a theoretical part because in postgraduate teaching we have to be thorough with that. But the problem with this is the availability of the test is a big problem, particularly in the areas where we are working. Suppose I want to refer a patient for these sort of testing, I have to refer them to Calcutta. From there, maybe the sample will be sent to Mumbai. This is a practical problem which we face. In our area, for example, fetal medicine specialists, a lot of them, Kanchanda, Dr. Prasanna, but problem is with the sample, and the patient becomes very anxious. By the time the results comes 2 weeks or 3 weeks, they become so anxious they want to somehow abort that pregnancy. So these are the practical problem faced. Remaining part, sir has already told very nicely. I need not add anything to that. So that's why history taking, clinical examination, and basic details about past history will be enough to guide us into next line of treatment.
So very well put, Dr. Indranil. You are a professor of repute and you have shown that today again. So it is basically screening test and diagnostic testing. Screening is done universally for chromosomal aneuploidies, and if we have certain disorders which are inherited, especially Mendelian disorders, so for that we have to order specific testing, which we will discuss subsequently. So thank you so much, Arup sir and Dr. Indranil. Dr. Prerna, again a very good friend. Uh, can you comment upon why the defects are rising in our country and the incidence which is increasing now, and what are the precise reasons behind them?
I can't see
Dr. Prerna is here?
so can somebody, we
She
can
was
ask
just
someone
here.
else. Yeah.
So, Sita ma'am, if you can take up this question.
Yeah. One second. Prerna was just calling me that she can't join in. She's got some network issues. Yeah.
Okay. So, ma'am, please, can you throw some light on why the incidence of these
Yeah.
diseases are rising?
So sorry for that. I was on the call. Yeah. So basically, yes, birth defects have been there from the beginning, and they have possibly increased now because of the increased awareness and because of the increased pickup. Every person who gets pregnant has a background risk of 2% of any congenital anomalies. But if they have any additional risk factors, like they've had a previous history, if the family history is there, which might predispose the fetus to have a genetic defect, or if they have a medical condition like diabetes or any other drugs they are taking, all these factors will put into it'll increase the risk. So it's a basic genetic factors you can put in, and environmental, as you've put in, like infections if they put in, or drug exposure. So it's very important at the beginning when the patients and the couple come in to take a detailed history and to triage them as to where they're falling into a low risk or a high risk. And then accordingly, as we've heard, put them through the array of tests that we have in the first trimester whenever they present, because it's unfortunate that all of them don't present in the first trimester. Even so, whenever they present, not put them at fault for presenting late, because that's how it is. But take that opportunity of whenever they present, take a history, whatever available test is there in your armamentarium, in your setup, make use of that, and then give them a risk so that at least they can plan. It's very, very important. Sometimes these patients come with a loss and they don't want to talk about it, because they have gone through so much. So if you probe in a bit, take it more sensitively, they might have some picture of somewhere, stored. So if you see that picture, and if you might get some ideas about the clue, because a lot of times some genetic tests are not done on the proband, as we call it, and we lose vital information. So all these things have to be there. So you don't be judgmental about it. Don't blame them, because it's nothing that they have done or they have not done that this has happened. So be very sensitive, be very positive, and be there to help them, so that we can say that nothing is lost. We can still try and prevent it further from happening. So that's how, and I think it needs very tender, loving care. Is a lot goes on here in these pregnancies. Oh, Prerna's here.
So true, ma'am. So true.
Good afternoon.
Welcome back, Prerna. So I'll just put in the way.
Thank you, Dr. Niharika and Dr. Shaila. Thank you,
Sorry,
ISPAT,
Prerna,
for this
I
wonderful
answered your
opportunity to be
question.
here. And really, No, yeah, I was not able to log in that time. And I just one thing I want to highlight is that the emotional parameters needs to be very much put into the entire phenomena, because once these mothers, I too have a brother who is having such birth defects, 30 years old. Just a personal input into this, that the emotional perturbance that we have with such children for last 30 years, we need so much of strength, and so much of the caretakers also need a lot of maybe put out of it. So emotional setback is the most important thing that we need to handle with care, as ma'am has already said. And thank you, ma'am, for giving your input into my question. Thank you.
Thank you so much, Prerna. So, as a team ISPAT, we can put it
Dr. Sheila?
that 20% of these disorders have genetic etiology, and so we are here to discuss that. So, I believe Mrs. Lakshita,
Before
we
the
have.
next question, I just want to add one thing. That is the important thing that should be discussed successfully. There are some medical disorder be considered. That is the diabetes. Diabetes is very important, and the medical disorder that we cause, other than the infection and all other many other things. So pre-conceptional and also during the conception. That is your awareness of the diabetes is very important in the answer to the previous questions. Diabetes is gestational diabetes or gestational diabetes congenital defect is less, but particularly the diabetes is more. So that we should always remember. So continue. Very sorry to interrupt.
Yes, sir. Thank you so much. And diabetes is a big menace and rising in our country. So, Mrs. Lakshita, we would like to know from you, what are the essentialities of genetic counseling? What, as an obstetrician and general practitioners, we should know about it?
Thank you so much, ma'am, for the question. And so basically, while doing the counseling, the two things that which we keep in mind is the pre-test and post-test counseling. Because genetic tests are something which are not very, which are not very aware. People are not very much aware of those tests, and especially the laymen, they are very much scared when they get to know that they have to go through a genetic test. So before undergoing a genetic test, they need the couple, the proband, the family has to be counseled in such a way that they know what test they are going for, what will be the outcomes, what will be the results, positive, negative, because most of the genetic test reports are not just the positive or negative reports, or they don't have a particular ranges like other tests. So in that case, we need to tell them in detail what the test they are going through and what will be the outcomes. And once the reports are out, it's not just that it's our duty as clinicians that we need to make them sit and need to make them understand each and every aspect of the report, rather than just saying it, okay, your child is, for example, your child is having Down syndrome, or this report says, the karyotyping report says that it is trisomy 21. So in that case, we have to tell them each and every detail. Plus, after the post test, we also need to tell them what are the risk of recurrence in further pregnancies. And also here, I would like to highlight the pre-test and post-test risk. So as we know that every mother has a risk of having a baby with any birth defect or with aneuploidy or monogenic disorder, which is very uncertain. So to calculate the risk, we have the initial risk based on either the age alone or a biochemical risk, which is termed as a priori risk or a pre-test risk. So if we calculate this risk, so if the ultrasound markers or the biochemical markers are there, so in that case the risk increases many times, like, and it comes out to be the risk. The pre-test risk comes out to be a likelihood risk. When I say likelihood risk, it means that there is a slight chances of having a risk of that particular condition. So if we multiply that likelihood risk with the pre-test risk, it comes out to be the adjusted risk. That is the post-test risk, which we call as when we get a report, that is when we consider it as a post-test risk. So this is what something I would like to highlight here, that the risk assessment is very important. So in pre-test, we need to give them the tentative risk, and once the reports are out, we need to give them the accurate risk that yes, this is what it is. And now Depending upon that post-test risk, we can further plan for the what we can help them for the next pregnancies, and we can calculate the risk accordingly.
Thank you so much, Lakshita. And yes, we adjust the background risk with certain tests, especially ultrasound and biochemical markers. So, moving ahead, we see that aneuploidies risk are increasing, and we have to identify universally, as the ACOG now is also recommending. So we modify the background risk using ultrasound and biochemical markers, as I just said, and identify patients for further invasive testing. So next slide, please. Yeah. So Dr. Vivek Kashyap, thank you for joining. You are very important to all of us today. We would like to know about the NT scan, as we have been talking about first trimester screening based on ultrasound. So why it is important to do the universally, why it has to be adopted, and what are the measuring guidelines, what are the things that we have to keep in mind?
I thank Shaila and Niharika and the team for including me in the panel. Now, this is where everything starts, no? And when we look at the NT scan, the first thing is that the size of the fetus is very important. So it has to be between 45 millimeters to 84 millimeters. So in the precise area where we are trying to look and concentrate on the NT, that is the time where we look at the entire fetus and we measure CRL, crown to rump length, and make sure that it is more than 45 millimeters, because anything less than 45 millimeters will not be accurate. Anything more than 84 millimeters will also not be accurate. So that is, having said that, then we go down to identify that what is the correct method to look at the NT, which means that we need to magnify the image and make sure that it is a sagittal section. So the sagittal section, which means that we should be able to see only the fetal head and the upper thorax in that section. Also, that we should only fetus should be in a neutral position, which means that there should be some fluid between the chin, and the fetus head should not be overflexed or hyperextended. Also, make sure that it is very, very wrong to measure the NT when the fetus is in a prone position. So we need to wait for the fetus to come back to supine position, be in a neutral position, take a mid-sagittal view. Yes, it is challenging, but then that is what the whole matter is about. We should be very patient. We should work very hard to get a proper section. And yes, these are all bad techniques. Here in the one technique, which is on the extreme left, we see that this is not really a true sagittal, because we can see the bone between the nasal bone and the maxilla, and that which means that this is not a true sagittal. We should not see any bones in between. We should be able to identify the nasal bone and the nasal skin as an equal sign. We should be able to identify the diencephalon very nicely. We should be able to, this is also the view that gives us much more information. And then to measure the NT is also very, very important. We must measure the NT at the largest diameter. If there's sometimes if there's a cord around it, so we should avoid the cord or measuring the cord. We should be very careful in identifying the skin and the amnion, because sometimes what happens is we may mistakenly measure the amnion, which could be enhancing the false measurements. So we can wait for some time, let the fetus move, and we are sure that this is skin and not the amnion. This is also the area where we can rule out cleft palates also, because that is also an important marker for trisomies. Nasal bone is also one of the most important markers for trisomy. So not only the NT scan, this ultrasound will give us the nasal bone. If it is properly ossified, it will tell us if there's any cleft palates, or even the shape of the head, which means if there's any frontal bossing. We must know that even skeletal dysplasias will give us a false or a increased NT, and all of this, I think, is the most important issue here when we talk about aneuploidies and the screening and trisomies, is a proper NT scan, and that one picture is the mainstay of all the issues after that.
Thank you so much, Dr. Kashyap. I think this is the game changer. And then NT should be measured according to gestational age specific standards that we have been provided. So thank you so much for your valuable inputs. Sita ma'am, I would like to request you to take this question as Naren Malhotra sir is slightly busy right now. Screening, who should be screened and when should ideally they be screened? Just two liners for the benefit of students, those who have joined.
So basically, we are screening these women to find them at risk. And as traditional would say, as we know that as age increases, a 40-year-old woman is at risk of 1 in 100 of having a baby with trisomy 21. But most of the Down syndrome babies or most of the aneuploidies rather occur in women less than 40 years of age or younger age women. So keeping that in mind, I think the dictum should be to screen everybody universally and not just restrict to age-wise or anything. And that is where the main bottom line is, that screen everyone and screen the way, as Dr. Kashyap has said, do a first trimester. A well done scan is almost half the job done. So if you do a correct nuchal translucency, you look at the ultrasound markers, any abnormalities or soft markers, and then also combine the biochemistry. The biochemistry can be done earlier because it's slightly more accurate, but because of the the problem of compliance patient coming back again, we tend to do them ideally between 12 to 13 weeks, because that's when the anatomy can be assessed quite well. And in skilled hands, almost it has a good pickup of all the major incompatible anomalies up to the range of 90%. And you can also combine the biochemistry. And if you do all these screen, as you have said, it has a good detection rate of about 85 to 95% when you combine the PAPE and the free beta STG for a false positive of 5%. And of course, if you have the additional markers like nasal bone, which is a very important soft marker, a negative soft marker for trisomy 21, and the other Doppler parameters like tricuspid flow, regurgitation, or ductus venosus, increased PI or reversed or those are also will add to your markers, but eventually it increases your sensitivity of detection and decreases your false positive, so that we don't unnecessarily do an invasive and reduce the invasives for these ones. So, but if you miss these women in the first trimester, again, as I said earlier, all is not lost. We can screen them in the second trimester by the quadruple test. So the basic point of any screening test is it should have a detection rate of more than 75%. So which is why the triple test, which has, less than 75, which is 70%, we don't use them anymore at all. So if a lady comes in the first trimester, you do your first trimester combined screening, add your markers depending on what software you're using, or the other parameters. You can add PLGF also. But if you are using in the second trimester, then you use a quadruple test, which combines your unconjugated distriol and inhibin A with serum alpha fetoprotein. And each variable has a significance in itself. Even if it does give you a risk of the overall combined, as we call it, it gives you a risk of aneuploidies. Each variable also has a significance in monitoring these pregnancies, like a PAPE, low PAPE can tell you if the baby is at risk of growth restriction. A high serum alpha protein will make you look at the spine more properly, and also a risk of growth restriction. So all these things can also add on, and you can screen them in general for aneuploidies as well as for other conditions.
Thank you so much for being so elaborate, ma'am. And just one word from all of us, that none of the markers in singleton parameter should be used to calculate the risk for aneuploidy especially.
Absolutely.
But we can anyway use it for FGR and preeclampsia
Just
detection.
one more, Sheila. I just want to also say that some of the reports, they tend to divide, and the patients get confused. They give a age risk, then they give a biochemical risk, and then they give a combined risk. So age is definitely not, they tend to see that and they tend to get worried. And even if the biochemical risk comes high, as long as your combined risk along with the ultrasound risk is low, please don't consider it as high risk. And then people tend to jump, oh, she needs an amnio or something. The overall risk has to be considered. Yes, the variables need to be noted. As I said, the PAPE moms, the beta SCG moms have to be noted. But the combined risk, as you said, is what has to be taken into consideration, and not the individual risks. Thank you.
Exactly. So we would come back to you, Dr. Vivek, absent nasal bone at 13 weeks, as you already mentioned about it. So what is the importance and how we should be going about measurement of nasal bone? Sir, please unmute yourself.
You're muted, Dr.
Sorry about that. An absent nasal bone is a major marker for aneuploidies, and besides other things. But the same way we should be measuring is that the mid-sagittal view of the fetal profile, and in which we are going to measure the NT scan. That is the section on which we can look at the nasal bone. However, the word of which may some of us may not agree is that there are actually two nasal bones. And so if we do a sagittal view, we are able to see one nasal bone. So I think for all our people who are doing our ultrasounds, they should make an effort to tilt the probe a little bit and make sure that there are two nasal bones which are ossified, because one single absent nasal bone will again make things not very bright for that pregnancy, because the risk factor would be the same. So in this image, the nasal bone should be different from the skin, which means that there will be two different lines, and the tip should be separate, which means that we definitely look at all the three things, that is the skin, the nasal bone, and the nasal tip. The nasal bone will be thicker and more echogenic, obviously. And if we are not able to see the two lines, then definitely there's something wrong. Which means that if we raise a red flag, call the patient again after some time, make sure that you are seeing the two lines. Because what happens is that sometimes we can take the nasal skin and we think that that is the nasal bone. So we have to be careful there. And it will be obviously much more echogenic if we adjust the machine parameters also. So we can look at the fetal profile, and in large majority of cases, it is quite comfortably seen, and thereby that is a very, very reassuring. But let us please remember that the nasal bone is absent in a large majority of trisomy 21 fetuses, trisomy 18, and trisomy 13 fetuses. A nasal bone absent means that we need to put this patient into a large, an array of testing. For a false positive rate, yes, there is a possibility that the nasal bone is not really ossified at that time, even in normal fetuses, which is just about 5%. So there we go, that we need to do much more than just maybe a beta HCG and a PAPE. And then we should be referring it to a geneticist or the clinician who's taking care of the pregnancy, that look, we are not able to identify the nasal bone, which is not ossified at this stage, and that is a major, major issue. Also, an effort should be made to look at both the nasal bones, and that is what I think is still controversial. A lot of people agree. A lot of people say that, okay, if you see that nasal bone in a mid-sagittal, that's enough. But I think I rotate the probe, I take a transverse view, and I see the V, which reassures me that both the nasal bones are present, and I rest my case there.
Absolutely.
Dr. Shaila, I want to add one thing here.
Yeah, please.
Very importantly, in our northeastern belt, there are so many tribal areas in Arunachal Pradesh belt. The people, they nose. And usually what we get in, very often we get reports by the NT scan that they say that's the absent nasal bone, and we have a very tough time to explain and that, okay, this might be constitutional, because, and we have recently delivered also 5 babies who had absent nasal bones in the ultrasound, and they were asked to terminate at other centers, but then ultimately the babies are quite healthy.
Yeah,
So
I would like to come in here, please.
Actually, the expertise also matters a lot. Expertise of the person doing the scan, because maximum scans are done by sonologists and basic even done by some homeopathic doctors in outskirts in Bengal. So we cannot believe on that. So many reassurance, and I think the gynecologists themselves should do the scans with due respect to radiologists, because my wife is also radiologist. So
I'd like to come in here. So saying that, everybody is an expert in their own way, provided they do it properly. And the first thing I would say is, there's a lot of, firstly, whenever you see the report, as I was saying, you also see the images. So make sure that whenever you're interpreting the report, that the image has been taken properly, as beautifully Dr. Kashyap has explained. And secondly, as he also said, we always measure the nasal bone in the sagittal as well as the coronal view, taking the premaxillary triangle and seeing the 2 dots of the nasal, both the nasal bones are there, because even if one nasal bone is absent, it equates to the same risk as having, the nasal bone. Secondly, as Prerna rightly said, isolated nasal bone is not a very uncommon feature in our population, especially from the population from the Northeast. So we have had women, so the protocol we follow in our institute is in the first trimester, if there is absent nasal bone, yes, the absent nasal bone is a very, very important marker for a trisomy 21, which increases the likelihood ratio, like the ratio by about 6.6 almost, because it's one of the major soft marker there. But if it is everything else is negative, the age, the other parameters are all normal, the NT is normal, so it becomes possibly a delayed ossification, as Dr. Vivek was saying. So we call this patient back again at 16 weeks, and if it's still absent, then we counsel the couple. Yes, it could be a possibility, it's because of your population based, it could be absent, but we cannot just assume it is just normal. So we can counsel them for an invasive, possibly amniocentesis, and we do the test. But we've had series of cases where we've delivered 5 to 6 women where the fetuses had an isolated nasal bone, everything else was normal. 4 of them had an invasive where they had normal CMAs. One of them refused to do any testing, and all the babies were actually normal to be born with. In fact, Dr. Vivek Krishnan's group also has published a study where they looked at all these cases of isolated nasal bone when everything else was normal, where the invasive testing was done. So we have to interpret this also isolated nasal bone with caution, but counsel them, offer them invasive testing, and document everything so that you have mentioned that there is a possibility of aneuploidy, which we are not missing.
We've thought of
very well said, Sita
replacing
ma'am.
Yes,
one
Dr.
little
Vivek.
small little point.
Yeah.
We think of replacing the word absent nasal bone with unossified nasal.
Unossified,
That
yes.
might be a little reassuring to the parents that look, this is unossified at this stage. Maybe it becomes ossified at a later stage.
Delayed ossification, and even for the risk, we don't say. I mean, I've heard Dr. Suresh sir saying, and we've adopted their policy, saying as we don't call it as high risk and low risk, we say high probability and low probability. So that when you play around with these words, it sort of also plays on the minds of the couple. They don't feel very negated or very disillusioned by the whole thing. Thank you.
Thank you, ma'am. So as you know that when we did this case, so we combined it with a dual marker and it screened positive for trisomy 21. And when we did again an ultrasound at 16 weeks, there were multiple anomalies which were seen. So absent nasal bone or nasal bone hypoplasia is something which we should not take lightly. As today we are trying to discuss common cases which we see in our OBGYN practice, like a abnormal NT or absent nasal bone, and the next one today we are discussing is echogenic cardiac focus. Dr. Shela? Yes.
Yeah, and for this, I would like to welcome Naren Malhotra sir. Sir has joined. Is sir here?
Good evening, good afternoon, sir. Good morning, sir. Sorry. I can see you.
I just saw sir. वो sunshine तो है sir वाला.
Good morning, sir.
So, okay, so we'll go ahead with the test. Dr. Niharika, sir will be joining.
He has joined. I can see him, but I think his network is an issue.
Yeah, you can see his but it's muted. You can't see his face.
So let's start this case. So this is a 32-year-old primary gravida with a normal NT-NB scan, and on an ultrasound level 2, she was told that her ultrasound report had 2 intracardiac echogenic focus. A very, very common report which most of us OBGYNs see in our day-to-day practice. And now what next is our protocol? So this report has come to you, and as an OBGYN, so let's maybe we can ask Indraneel till sir joins, or to take this case. So she's come to you, Indraneel, and with her first visit, what would you do next?
See, the dual marker, it is a low risk. First is reduce the anxiety of the patient and tell that it can be an isolated situation and there is nothing to panic over here. Now, best thing is, she's how many weeks? I didn't get that, Niharika. How many weeks of gestation?
She's come for the anatomy scan, so maybe around 19, 20.
Anomaly scan.
19 weeks.
Okay. Okay, 19 weeks. So I think we can go for the non-invasive testing, that is the NIPT. And we can use the NIPT test to our benefit just to rule out in case. But I think it should not be a problem, and reassurance is the main part of the counseling. Now, she's having an isolated echogenic foci, right? So this isolated echogenic foci, sometimes like a lot of doctors in the peripheries, they'll try to scare the patient that there is something wrong with the report or something wrong with the heart. So again, reassurance to the patient, NIPT can be done to confirm and help in our testing regards. And we can repeat the fetal echo at around 22 to 24 weeks just to rule out that anything is wrong with the cardia. So I think that will be the way to proceed with this particular case.
Sita ma'am, your input, yeah.
Yeah, I think with an isolated echogenic foci, the risk of likelihood ratio, it has the lowest in the risk of trisomy 21, which means the background risk remains the same with isolated echogenic foci. So if you find it, at least I think the routine protocol, I would love to hear Dr. Kashyap's views as well. We don't offer an echo or an NIPS. We just reassure the patient saying it's just a prominent capillary muscle of the heart. We don't need any follow-up or any invasive testing if the combined risk was low and if there are no markers.
Fetal echo is not indicated in cases of isolated echogenic intracardiac foci. The only thing I can do when the patient comes to my clinic with the report is that I make sure that the person who's done it is properly qualified. I look at the images. If they are not, good images or quality images, I can talk to the patients and their clinician that we can do a repeat anomaly scan, and I look for carefully for the other markers. Which means that if not just the isolated intracardiac, but I look at the pilectasis and things like that, nasal bone maybe, and the nuchal fold and things like that. Now, if there is multiple, then we need to raise a red flag. If there's an isolated intracardiac foci, I generally tend to say that, look, you don't need a fetal echo. But then these days is a different day altogether. And the patient and the parents say, no, we want a fetal echo because somebody said that there's something in the fetal heart. So I try to explain, but then sometimes we have to agree to the demand of
No,
the
another
parents.
problem what we face, sir, what you have told correctly, problem is the radiologist himself or herself will write that suggested fetal echo. Then what is the situation? Then I think you have to proceed with that.
No. So that there lies the thing that we all should speak the same language. We all should not be giving. All of us should say the same thing. If we say that echo is not required, even if the evidence says the echo is not required, I think all the obstetricians, the radiologists, whoever is scanning or counseling the couple in the clinic should say the same thing. Because if one person says something different, then obviously the patient gets confused.
No, it works all the way. I see so many situations here where even if I've done a anomaly scan and I have probably mentioned that there are two echogenic foci, the clinician will ring me up that, doctor, can you do a fetal echo? So it works both ways. I think we need to get together and share this amongst ourselves so that there's one language being spoken for all the people who are involved in the care of the fetus.
Absolutely.
So, having said that,
Actually,
another
this is
issue.
the singular aim of putting up such webinars that we
Yes.
speak the common language. Yes, that's why the
Yes.
diversity of inclusion.
I think
So,
actually it's very.
yes. So, Mrs. Lakshita, we have a question for you. We are now having direct to counter tests, right? So, how good are they, and how should we go about this proper situation? Like we were just discussing that patient herself will say, "Ki, do my echo or do my this test or that test." So, how do you counsel the such patients?
So, ma'am, if a patient walks in and these days patients are well aware of that we can opt for this test, we can do for this, we can go for the other test. So, in such cases, it is very important for them it is very important for us to make them understand that if the first child is affected or if the fetus, we cannot do a direct testing on the fetus because there are multiple factors are involved, and it is one of the key rule that direct testing on the fetus until or unless if we have not tested on the previous child or the affected individual, it is not recommended to directly jump and test for the fetus, even if we have a evidence. So in that case, what we do is we usually counsel the patient that once the fetus, if the lady is in early stage, in that case, what we do is we ask her to go for the test for the affected individual in the family, or maybe the sibling or the mother itself, whoever is affected in the family, and then depending upon that, depending on the reports, we offer the test on the fetus. But now, if the case is where the mother is already, I would say maybe in second trimester or almost she's completing her second trimester, and then she comes, then she visits, then what? So in that cases, we definitely need to do the detailed testing of the detailed ultrasounds or detailed screening, I would say. Depending upon that, we would offer the segregation analysis with accordingly for the fetus, then for the parents as well, or the affected individual as well, to save the time. Because if in somewhere around 20 weeks, if we got to know that there is some that the previous child was affected with skeletal dysplasia, and this patient has come up first time, and in ultrasound findings also we have found out slight features of skeletal dysplasia, then we would the ideal way to go for is to go first to test the affected child. If not, because she's already 20 weaker, so what we will do is we will counsel the patient in such a way that the first child also get tested and the fetus also get tested. So here the especially at the point at this point of time where it is very important, very crucial for them to understand. So we need to offer correctly, because again, while offering any sort of genetic test, it also involves economy, which plays a very important role. And the patient, once they hear the price of any particular test when it comes to genetic, whether it is microarray or exome sequencing, or for that factor, even the karyotyping, they think twice. So genetic counseling at that point of time and telling them the importance of particular test is very important for the not only for the fetus but also for the entire family.
Exactly, Lakshita. Actually, we should know what we are searching. So if we
Exactly.
have that answer, we can order the test and we can counsel accordingly. So,
Right.
Sita ma'am, I have very interesting case for you. A woman presented at 19 weeks of pregnancy with previous child having autism and intellectual disability. So, how should we as OBGYN practitioners go about this case?
Yeah, this is one of the common scenarios that we face. And obviously, autism spectrum disorder is such a vast disorder caused by so many factors, we can't really pinpoint it. So whenever a patient comes to it, we have to get the proband into the picture. So get the child, the whole family, and you have to have a multidisciplinary approach here so that we have a geneticist, genetic counselor. So we have to have a detailed history as the pedigree chart, what is happening in their family, what is the actual situation of the baby, how badly it is intellectually disabled. And then as if the child is alive, then of course we have all the information there. So we have to test the child. Now, obviously, autistic spectrum is not something which is, a pinpoint. So ideally, though we would, there are a lot of causes. So I think the test that would be recommended is a whole exome here, because we really cannot rely on the karyotype or chromosome and microarray, just looking at the chromosomes and making sure that everything has been excluded in this family. So if there is a pedigree chart and if that comes positive, and then we can track it back to what sort of a disorder this is, if there is an inheritance pattern to it, then of course we take it that way. But once we have the picture in hand, as Dr. Lakshita said, it's no point doing a test and you find a needle in a haystack. We have to be exactly sure as to what we are looking for, and then put the needle in the fetus, because a sample is so very important. And so that is how the whole, so autistic spectrum is not a very easy thing to deal with, and the patients are obviously want to know the answers in this pregnancy, that my baby will be 100% fine or not, which is something we cannot always assure, because nothing is 100% or 0% in science. So we can do with whatever test that's available. And since we have the index child in hand, we can make use of that, do the tests, and then descend depending on what we find. But the problem with these high range tests are, we also come across things that we may not be suspecting, like that is called variants of unknown significance, which may be clinically insignificant today, but tomorrow they may be significant, as in, if the woman releases it as a significant disorder where the genotype and the phenotype matches. So it is very, very important for a pre-test counseling about these patients as to what we are testing them for, not just a blood test looking for hemoglobin. It is a test which is looking at all the genes there, and we might be pick up things because which may be phenotypically normal, intellectually normal. So if that has to be interpreted with caution, and out of the 10 people sitting here in our faculty, we might have one or two which have some variants of unknown significance which are not, and we're all fine. So all these things have to be interpreted with very, very caution and deal it. So we have to, as you have rightly said, not everything on a report is a cause of disease. So that is also important to counsel them. So both pre-test and post-test counseling is very, very crucial here.
Our aim here, ma'am, to put this case was that because we have a child with a defect, so as OBGYNs, we also should start counseling to actually investigate that child first.
Yeah, absolutely.
Because that's the most important thing which could be done in this situation. And
Yes.
that's what we are aiming at. So it's for OBGYNs to counsel that, because unless we don't start or we don't know it ourselves, we won't
We
be
don't
able to
initiate
counsel
it. Yeah, yeah.
so each situation is very unique, and so is each fetus. And we have to deal with the antenatal, postnatal scenarios combined together. We do have a lot of cases around, but we'll actually go to our last slide now because we are running short of time. And let's take this small case, and Arup sir is here. And we all deal with now elderly women coming with IVF pregnancy. So 44-year-old woman, sir, come to you with self-eggs IVF, was treated for primary infertility. Now she has come to you at 10 to 11 weeks of pregnancy. What will be your protocol to screen this patient?
Thank you, Niharika, for this question. This is actually already described. This is the age factor is the important factor. So we will have to proceed from the very beginning, other than age factor, whether there is another medical disorder. Because 45 years, there may be some medical disorder, we'll have to count that. And also from the routine, we'll have to do the aneuploidy screening in the first trimester. That is either by the combined skin or NIPS, NIPT, or both can be done. The screening test. And according to the screening test, we will go whether whether the high risk or low risk. Definitely, it will be there is a risk as the age factor is the important, and possibility of the trisomy Down syndrome is the commonest, is the common. So according to the risk, we will go for the invasive test. We will go to either after 12 13 weeks of pregnancy, we will go for the amniocentesis or like that, the invasive test, and example and examination of the tissue either by the genetic testing like microarray is the best, or fish technology. So these and then most important thing is the counseling of the patient or the possibility of the fetal disorder in this patient.
So thank you, sir. So as we know that she's already above the age of 40, so a risk factor when we think of, it's about 1 in 19 chance of her getting an abnormal fetus. So we have to now deal with this patient a little extra. And yes, we are in a era where we are changing from routine ultrasounds to NIPS for all, and maybe in another 4 to 5 years, we might be offering NIPS to all elderly women as first line treatment, because it is a easy test with accurate testing, and this patient does fall into that maternal age high risk category. So she can be offered a combined testing or an NIPS as early as possible and then taken ahead. Let's end our panel now with the last take home message by all of you on what advice we would give to our antenatal mothers to reduce the incidence of birth defects. So we can start one by one, sir. Arup sir, from you, and then we'll go ahead.
The most important thing is that you first consult the doctor, your obstetrician and gynecologist, who are going to plan. And The doctors will say you what are the problems with you. Some investigations also examine your the body weight is important, the food habit is important, whether she has been immunized, particularly the measles, the German measles. And if there is any doubt, you'll have to do the antibody testing. And what is the weight? That is the very important thing. Weight. And I already stressed about the blood sugar. So this is the preconceptional thing is very important. And if she has already planned, and folic acid is important, supplementation of the folic acid 400. But Vicky, this is the one of the important thing in the obstetric that there's a definite advantage of the folic acid during pregnancy, not only the NTD to prevent the NTD, but many other things, and not with the combination. Actually, folic acid should be given separately 400 at least before 1 month to start the pregnancy. The preparation of the mother is very important, and including also the anemia and other tests. So these are the important preconceptional counseling and preconceptional adjustment to become the mother. Will have to advise like that.
Sita ma'am?
I didn't hear that. Yeah. Thank you, Niharika. It was a wonderful panel. And my message will be that whenever the patient comes, if you're scanning or if you're taking an antenatal as an obstetrician, please take some time out to take a detailed history. If they've said a fetal loss, miscarriage, it might not be, for them, even an 8 months loss is a miscarriage. So if you prod in and say, then they will come out with details like, it was an IUD or something. So please take a detailed history because a lot of information is there. Take that. That will give you information as to how you can prevent recurrence of these defects, screen them properly early and by the proper methods, and look at your reports, look at your images, and always be positive and give them positive counseling so that they also don't terminate at the drop of a hat. And even if they terminate, just make sure they preserve some DNA so that we have some information for the next pregnancy, because that only costs 2,000 rupees. So that is at least affordable by all. Thank you so much.
Thank you, ma'am. Vivek sir?
I think it's folic acid, and folic acid. Studies have shown that preconceptual, if the folic acid is given or the fortified with the diet, it reduces the incidence of neural tube defects, the cardiac defects, and other defects by a huge percentage. And somebody says as high as 50%. So I think that is another thing. And advise the patients to avoid smoking, drugs, and all of that, besides, of course, hygiene. And then go to a good place where they can get proper advice. And I think we are all full of hope, and we should give a lot of hope to the patients that everything is fine. Do not worry so much. The incidence of defects is just about 3%. So 97% is all good. And with a ray of hope that everything will be good.
Thank you, sir. Indranil?
So the mother has to be advised about the basic things, that is early starting of folic acid, and obviously maintain hygiene, avoid smoking, alcohol. ज़्यादा alcohol नहीं लेना ही नहीं है. Then mainly early testing for diabetes. That is a single test of 75 gram glucose, just in case to rule out early diabetes, which can cause early anomalies in the patient. Rest all things have been told by esteemed panelists. Thank you.
Thank you, Indranil. And Lakshita, last one here. Lakshita, can you say a few ending words?
Yeah. So for antenatal mothers or for the preconception couples, those who come, so I think carrier screening for basic conditions, like whether it be thalassemia, SMA, and DMD is very important. So the couple should be and the mother should be aware of it, and these screening tests should be mandatory too, so that we can, even the recent guidelines also say, the Indian guidelines, that we should offer these tests, the screening test.
I'm also here, Niharika.
Yeah,
When
Prerna,
that is working. Yeah, just a word with prevention is the key. So primary, secondary, and tertiary prevention, we need to really assess and proceed for that. Primary prevention, everybody has given their input regarding folic acids and improving the environment of the mother where she is, with not exposing her to teratogens and her nutrition as well. And the secondary prevention, once detected, the anomalous thing that which cannot be corrected in utero needs to be terminated rather than giving birth to an anomalous baby. And third is the tertiary prevention of correcting of all those metabolic errors if the baby is born with. So that is all. Thank you very much for a wonderful panel.
Thank you, Prerna.
Thank you
And
so much.
Shela, you can conclude now. Thank you.
Okay, so thank you, Dr. Niharika, all the wonderful and esteemed panelists. It was a good, insightful morning, Sunday morning for all of us. And from Niharika and my side, I would like to say that abandon triple markers as first and second trimester screening because people are still doing that. Combined screening will detect 95% but still have 5% false positive rate. We can add on NIPS for that, but it is still a screening test. It reduces false positive rate by another 3 to 4%. Adding NB, nasal bone, and TR to our first trimester screening brings about false positive rate by 2.5% also. So we can add all to that also. For inherited disorders, as Lakshita just said, career screening is very important. Previous history is important. Pedigree charting and probanding analysis is very important. And CMA can be ordered for that. And genome sequencing gives advantage of detecting inversion and translocations which are missed by chromosomal microarray study. For OBGYNs, एक ही बात है, we just have to be, mindful that our patients can have it. Order a simple first trimester combined screening. If at all we detect anything, we can refer these patients to fetal medicine specialist and never order any test which we do not know ABC about what it is giving to us. So thank you so much, ISPAT, for giving us this opportunity. Thank you, Dr. Niharika. Thank you, Naren sir, Sita ma'am, Arup sir, and all the seniors sitting over here. Thank you so much.
Thank you, Shaila and Dr. Niharika, for a wonderful panel. Really, a lot of points brought out here. And thank you, Dr. Dani and Dr. Manjeet, for this opportunity. Thank you so much. Thank you.
Thank you, Niharika, Shaila. Thank you very much.
Thank you.
Thanks all of you, and thanks for making me a part of it.
Thank you. Bye-bye.
Thank you to the moderators. This has been amazing conversations, really very interesting discussions, and very clear and crisp take-home messages. It's been a really good panel. Shreyanshi, are you there?
Yes, ma'am.
Yeah.
So
Do we
thank
have
you
any
so much.
questions, or would we like to take it at the end?
Yeah, let me check, ma'am. Yes, we have received one question. I'm just putting in the chat section. Yes.
So Sita ma'am, Dr. Chanchala Shetty has asked that father has ankylosing spondylitis, and now how do I guide about the couple? She's 8 weeks pregnant.
Spondylitis. So again, we'll have to check whether, that there's any just a sporadic event or if there's any genetic cause to it. I think we'll take the help of our geneticists here and if see there's any inheritable condition. If yes, then decide on what the mutation, if there is, and then test accordingly. So I don't know if ankylosing, if it's routinely not associated with. Dr. Lakshita can also. Dr. Manjeet.
Hi, Dr. Sita, just one thing. Is ankylosing a genetic condition or an autoimmune thing? And do we have to do an autoimmune for?
Yeah,
Do
it's
we
usually an autoimmune. That's why I'm saying. So we need the
Yeah,
help of.
it's an immunological condition actually, so it's
Yeah.
not hereditary, so we can't predict
Yeah.
here.
I don't think there is any.
Can I comment?
Yes.
Can I comment? Yeah. So basically, there is a susceptibility allele for ankylosing spondylitis, which is called HLA-B27, but it's not like everybody with HLA-B27 will have ankylosing spondylitis. So we don't do anything prenatally. We can only counsel the patient and say that there is a possibility that if somebody has an HLA-B27, the risk of getting an ankylosing spondylitis is more, but there is no prenatal suggested in these cases.
Yeah, and actually, if 60% of them are actually B27 negative with no gene
Yes.
or no SLE panel to be positive in that cases also. Yeah.
No genetic associations.
So thank you everyone, and over to you, Niharika, to take over now from one Niharika to the other.
What a wonderful panel. And like always, Dr. Niharika Malhotra's panel is always a fantastic and a super hit panel. And the hard work she does behind each and every minute detail is commendable. So I hope I maintain the rhythm of the energy, and we'll just start with the sharing of the screen, I guess. Yeah.
Again, Dr. Niharika Tyagi, being a managing committee member, please introduce yourself and your co-moderator on behalf of ISPAT.
First of all, a very thank you from the bottom of our heart, and congratulations to the team ISPAT, especially Dr. Manjeet and Dr. Saurabh for working so hard day and night for this such a wonderful initiative. So I'm Dr. Niharika Tyagi, and I'm from Lucknow. I shall be conducting the panel along with my co-host Dr. Sarvesh Chandra Mishra. He's a fetal medicine expert, and he's the director of the fetal medicine unit in MSK. So I have a wonderful panelist all across India, and they say कि आप इंडिया का चारों जगह घूम लोगे तो you have traveled the whole world. So traveling the whole world, we have Dr. Raju Sahitya, the expert from Bombay, Dr. Nidhi Johri from Lucknow, Dr. Ajay Kumar sir, a very well-known pediatrician from Lucknow, Dr. Manjiri, a very successful pediatric surgeon from Bangalore, Dr. Jayesh Patel from Gujarat, he's a fetal medicine specialist, Dr. Veronica from MP, Dr. Varsha from Bangalore, and Dr. Deepanjana from Calcutta. So it is so good to have such a beautiful looking panel, firstly. Very, very nice panel. So we start with the birth defects being managed after delivery. Now, birth defects could be anything that could be at birth, as well as that could involve your structural abnormalities, or it could involve some functional abnormalities like hemophilia or thalassemia. And unfortunately, these are defects that are diagnosed at the time of birth. That is why birth defects. So the whole purpose of actually doing this webinar is to sensitize the issue of birth defect, not just Down syndrome being our only area of interest. Birth defects hold around 3% of the total population. That means 27 million babies are being born every year with birth defects. So that is the magnitude of our birth defects. So being 3% of the infants being born with birth defects, we need to understand this is a global burden that we have. And as gynecologist, pediatrician, and as well as our geneticician, it is our responsibility to be aware of the whole thing. Now, birth defects is just the burden. So birth defects actually have not just the burden of neonatal death or the neonatal death or being prevailing in the birth. It is basically the whole lot of things that happens after the mortality and the morbidity. It is the hospitalization, it is the economic cost, it is unnecessarily abortions, and the pressure on the parents and the family. So for classification and the domains, I would request my co-moderator, Dr. Sarvesh Chandra Mishra, please join us and go ahead with the first question and the panel discussion.
First of all, big thanks to the ISPAT committee for choosing us to be present here amongst the elite faculty here. So coming to the classification and the domains, we have three subheadings: pathogenesis, health impact, and the presentation. Classification pathogenesis is divided into four basic types. There is abnormal formation of tissue leading to valve malformation. There is unusual force on a normal tissue as in leading to deformity. Third is breakdown of a normal tissue leading to disruption. And fourth is abnormal organization of cells or tissue. The examples of each of one have been shown in the images below. As on coming to the causes of birth defects, there are a lot of causes. There are genetic causes, chromosomal defects, environmental factors, and multifactorial factors. But to our surprise, 60% of the patients, 60% of the fetuses have no known birth, no known exposure. I mean, there is no environmental factor, there is no multifactorial factor. 60% don't have any implicating factor. It can be either isolated abnormality or it can be part of a syndrome. Coming to the health impact, there can be a major health impact or can be a minor health impact. 3 to 5% of the fetuses have major health impact, which would lead to requirement of treatment or psychosocial support, and 10% of the fetuses would need minor support usually, and they do well without even treatment, as in a patient born with small pinna deformity. Coming to the case scenarios, we have first case here. A preterm infant is born by normal vaginal birth, and the patient had undergone an anomaly scan at around 20 weeks, where a cleft lip was documented, but limbs were reported to be normal. When the baby was born, apart from the cleft lip, the baby had abnormal foot. The baby had bilateral club foot. So the patient came to the OPD, and it was told by the patient that it was missed by the obstetrician, and had they knew about it, they would have aborted the fetus. So this is the picture of the fetus. We can see baby is born with cleft lip, ignoring the upper lip completely. There is bilateral CTEV. So coming to the questions, first of all, I would like to ask Dr. Ajay sir to tell us about the primary counseling regarding the neonatal care in such a scenario. Dr. Ajay sir, are you there?
Well,
yes, sir.
Am I audible?
Yes, sir, you are.
Okay. So a patient presenting with cleft palate with club foot, there could be two things. One is associated with feeding difficulties, and the other thing could be something which is cosmetic, which ends up with a lot of disability in walking and running, etc. So both the things are to be taken simultaneously. For feeding difficulties, one has to see whether the child is able to take the feeds properly, whether through it is there is an associated cleft palate also, or it is only solitary cleft lip. In case of cleft palate, the suction pressure created by the baby for breastfeeding is not adequate, and the child may be requiring some kind of top feeding, express breast milk by directly not from the mother's breast, but from external sources, external measures. It can be a passive feeding, it can be a gavage feeding. While club foot is to be taken care of as early as possible. They say कि cleft foot, club foot, if it is ignored as the time passes off, it becomes more and more difficult to rectify it. So the first thing is one should keep on trying to manipulate the club foot so that it comes to the normal position, and later on some kind of orthopedic measures can be adopted.
Okay, thank you so much, sir, for the opinion. Now coming to the next question, Dr. Nidhi, would you like to tell us regarding the responsibility of an obstetrician in such a scenario?
So if Dr. Nidhi is not there, Dr.
I think Dr. Nidhi has not joined yet. If Dr. Raju sir can share his experiences and thoughts regarding this.
Thank you very much. And see, as an obstetrician, talking about prenatally, when screening is become absolutely cannot practice obstetrics without proper screening. And the ultrasound is a great modality. Can you hear me?
Yes, sir, you are audible.
And the ultrasound has become a great modality. So when we have this living in an era where anatomy scan and anomaly scan is possible around 12 weeks of pregnancy, one should not miss such defects. Although cleft lip can further at around 14 weeks could be diagnosed. So counseling is the key, because we should know that 6% of these orofacial clefts are chromosomally dependent. So when you have a case where you see and confirm by 14 weeks that there is a cleft lip, that is the orofacial cleft is there, one should counsel and should search for other abnormalities, because this is carried on and it is 6%. It depends on the chromosome. So counseling, you should not overtly counsel or you should not covertly counsel. You should not scare the patient, because there is a possibility that this could be a solitary defect which could be followed and managed by the pediatric surgeons, or it could be associated with many other defects. So therefore, at times it is better to counsel to undergo a prenatal diagnosis, which could be in such a situation when the confirmation comes around 14 weeks, by doing an amniocentesis, counseling for amniocentesis. At least you should inform, and you should continue to follow up ultrasonographically 16 weeks, 18 weeks, and when you are sure that this one needs an invasive technique to confirm whether there are some other defect or chromosomes are at stake, then you should do an invasive prenatal diagnosis and you should establish the fact.
Sir, would I like, sir, sorry, sir, to interrupt. I would like to add one more point, that in such patients where we have already diagnosed at 14 around weeks that the baby might be having a cleft lip. At that point of time, medico-legally, we have to rule out the other congenital defects if possible in that baby. And then if the situation arises, we have to write that we have already advised. Simultaneously, we are counseling also, but the invasive tests are also at the same point of time should be advised. That's medical legally.
That's perfect. That's perfect. That's what I meant. That once you have checked and screening is being done and there is a diagnosis, you have to counsel the patient, tell her the possibility.
And for other abnormalities as well.
Yes, that's what you have to. I said we are fortunate to be living in an era where anatomical defects can be detected as early as between 12 to 14 weeks of pregnancy. So you are not pardoned if you miss something additional. You must continue your search thereafter, but you must counsel that this
counseling is the key. Counseling in such patients is the key. And at the same time, you should not scare the patient also, because very many times, if it is a solitary lesion, it can be repaired at a later stage. So that is what the obstetrician should always keep in mind. I think the major responsibility lies with the obstetrician, counseling and counseling and counseling. Thank you, sir.
I think our next question has already been answered. Dr. Jayesh Patel, sir, if you want to if you would like to add something.
I'm online, Dr. Jayesh.
Is Dr. Jayesh sir there?
He has to just unmute himself.
Wow. Hi, Dr. Jayesh. I think he seems to be online.
He's there.
Yeah.
Sir is there.
He seems to be live also. Hi, Dr. Jayesh. Can you hear us? Should we can come back to him, unmute, sorry. We can come back to him later. Dr. Jayesh, you are not audible. Anyways, I think we can come back to him later. Yeah.
टेंशन राजेश का है, तो तुम इधर वाला बिस्तर ठीक कर दो। आई नहीं है वो रेखा जब
Hello everyone. Hi, I'm Dr. Veronica. Sorry, I joined late. Hi, Niharika.
Am I
Hello,
audible
Rajesh.
now?
Hello.
Yes, sir, you're
Am I
audible now.
audible?
Yes,
ma'am, you are.
Hi. I just wanted to add a small point over here is that majority of our obstetricians, what I've noticed is, I mean, they are working in smaller settings, including me.
Smaller settings in the sense that I work in a low resource area in a part of Chhattisgarh. So what is happening many a times, many of the obstetricians are not primed about the early anomaly scan. That can be done as early as 14 to 16 weeks as part of the counseling. And we should advocate, spread a message about this early anomaly scan where these type of anomalies can be detected early.
But I just want to add, and I want Dr. Raju to comment on it. When you are doing a proper 12-week scan, Dr. Sarvesh, please say, would you advocate, and everything looks fine in a 12-week scan, would you advocate an early anomaly scan, or would you like to place the patient for a proper 18 weeks, 20-week scan?
See, you very well said that at 12-week scan, if you're finding everything fine, there is no need to, panic the patient by saying that she will require an early scan. The question will be, she will ask you why, and you have no reason to tell her that. Even 18 weeks is good enough early, and you can do lots for that patient. Even at 18 weeks, if you pick up some more markers which may point at a chromosomal problem, and then you can intervene even at that stage. So therefore, it is no need, when we are in an era with good machines, where between 12 and 14 weeks, almost 97%, 99%, we are established that there is no anomaly. Then there is no need to hurry up at 14 weeks, 16 weeks. You will go on repeating that, and you will come to the same conclusion. So if you find something wrong between 12 and 14 weeks of pregnancy, it is only then you could prepone around 16 to 18 weeks to reassure that patient or reconfirm that situation. But if all is fine, there is no need to do all that. You can go ahead to do a good ultrasound and anatomy anomaly scan between 18 to 22 weeks of pregnancy and establish once for all.
Yes, sir. When I mentioned about the
Niharika, excuse me, I would like to add just
early anomaly scan. Sorry. Early anomaly scan to be advocated in only those patients where some finding has been achieved in the NT scan. Right?
That's what I said.
meant that already. Yes, sir. Yes,
Sir,
sir.
I would
So-
like to add one more point. If there is a patient who is high risk pregnancy, or a patient who gives us a history of a previous congenitally defected baby, in all those patients, would you not like to do another scan? Maybe a NT scan was normal. But in such patients, I think we should definitely do a repeat scan.
See, the number of scans what you want to do, there is no upper limit to that. My point is, you said, and the case was that between 12 to 14 week scan, NT was all right and everything else was reported all right. There was no anatomy abnormality, neither anomaly. Having the past history, if you counsel the patient and you tell her that you want to do one more at 16 weeks, it is no harm to do that. But what you have seen in current scenario, you need not counsel and put her to that strain that she could be carrying a defective child. Doing an extra anomaly scan doesn't matter, but anxiety we have to understand, and also we have to understand that if by 14 weeks, when you can beautifully see everything, you can see and rule out defects up to 97%. And if all is well, 18 weeks is good time where you will not have to do it again and again. And now with the new MTP rules and all that, between 18 to 22 weeks, you can establish most of the conditions. You can do an invasive amniocentesis and do all the possible genomic study, microbiological, molecular study, and you can establish a problem.
Yeah, thank you, sir, for making it so clear. Thank you, sir.
Thank you so much.
Am I audible now?
Yeah, Dr. Jayesh.
Okay. Particularly in this case, intervention could have helped because first of all, once you detect some anomaly, always try to look for another anomaly so that we can come to a conclusion whether we are dealing with a isolated anomaly or with some syndromic situation or associations. Once you are sure that it is an isolated anomaly, then you have to decide whether this anomaly is requiring some intervention. For example, cleft lip palate, they are associated with chromosomal anomaly. So intervention in the form of either, if we have detected in early, that is 12 to 14 weeks, we will go for Korean biopsy, or if we detect it late, then amniocentesis can be offered.
Thank you so much, sir. As sir has already explained regarding the need for the invasive testing, going by the basic classification, you see that 30% of the fetuses have syndromic association in case of cleft lip and palate. So a lot of genetic factors have been, a lot of genes have been implicated already. Apart from the environmental causes such as smoking, alcohol consumption, anti-epileptic medications, steroids, nutritional deficiencies like folic acid, along with infectious diseases, certain enzyme deficiencies have also been implicated in the as a causative factors such as NAT1, NAT2, CYP1A1, and GST enzymes. Various genetic causes have also been implicated, as I've already told in the previous slide. So there is a research where a prevalence of aneuploidy and additional anatomic abnormalities in fetuses and neonates with cleft lip and with or without cleft palate has been studied in detail, and need for invasive testing has been advocated for. So this is the image we can see on the right side. There is a the palate, hard palate is not seen. This is a case of hard palate clefting, complete cleft of hard palate. So next I would like to ask Dr. Manjari ma'am if she could give her expertise regarding the need for the surgery in such cases. What exactly is the right time, for how long should the patient wait, and how should we counsel the patient regarding the need for surgery and the timing of the surgeries?
First of all, I take this opportunity to thank ISPAT for including me into this panel discussion. I think pediatric surgeon, they play an important role and they should be made a part of counseling and the antenatal level itself, because there are a lot of advances now. The cleft lip itself, it doesn't cause any abnormality in feeding. If it is a complete cleft or partial cleft, whether it is bilateral cleft, that needs to be ruled out. And if it is non-syndromic, then these children, they do very well. Nowadays, along with the SMILE organization, good methods of repair of this cleft lip is taken up. After the age of 4 months, after the initial vaccination schedule is complete, then these children can be subjected to the early repair as early as 3.5 to 4 months. And if it is associated with the palate, then it is coordinated well and done. So as far as palate is concerned, for initial feeding purposes to prevent the regurgitation, there are now the diaphragms are available which can be placed according to the size of the palate, and the feeding can be taken care. It is not actually a major threat for the life. So since these are not life-threatening situations, these children will definitely do well. And as far as the clubfoot is, there are different degrees of clubfoot. Initial stabilization of the joint can be done by the cast application in the NICU itself. And later on, depending upon the growth of the bone and the muscle, the cast is changed, and the corrective muscle transfer or tendon transfer surgeries can be taken up once a child reaches around 12 months to 14 months of age.
Thank you so much, sir.
I would like to add here that even if prenatal chromosomal study or genetic study is not done, we can do it postnatally also in such cases.
Yeah. Thank you so much, ma'am, Dr. Manjari and Dr. Jayesh. As we have already discussed, a patient with cleft palate, cleft lip, and with clubfoot, they require a multidisciplinary approach, and all of us have a role to play in. And as you can see in the chart, there are various inputs given by various specialities depending on the time. So it's a multidisciplinary approach, and a good team would result in a good outcome for the fetuses with such abnormalities. So a lot of organizations are already working.
Can I ask one question? When is the earliest repair of these defects can be done? Because it is it is a morbid condition when there is cleft lip and cleft palate to handle the child feeding and all that. So when is the earliest repairs can be done? Dr. Manjari, if he could answer.
Yes, sir. Between 3 to 4 months, as I said, it is the easiest one because this child has to be under general anesthesia. And if the weight of the child is good, then anesthesiologically the risk is less. And managing the child post-operatively, just to see that the repair doesn't get disrupted, is also easy if the child is around 4.5 to 5 kgs. So that is possible between 3 to 4 months. That is the earliest time when we can do. And as I already said, that if it is only isolated cleft lip and not the palate, then feeding is not an issue. Palate feedings can be done. There are specific long mouth palatals available for feeding these babies, and they do grow well. So in clinical practices, we have not seen any babies having feeding issues or delayed growth because of this feeding issues due to particularly cleft lip.
I have been told that you must follow the rule of 10. The baby should be
So
at
that
least
was
10 weeks,
that was old.
10
So that
pounds
was,
and 10 gram hemoglobin.
sir, in 10 weeks, no baby will become 10 pound at
Yeah,
least
but
in
just to
India.
clarify
But
that.
no, those were in olden
Actually, it
days
is
that
10
was
months,
followed.
not 10 weeks.
That was 10 months, and it is the olden rule. When we were students, we used to learn that. But as I said, that with the modern amenities available, the newer suture materials, the microscopic view of the surgeries, and newer node surgical microscopes and innovations happening in the surgical field, we are able to do it in younger children more and more.
Thank you, Manjari. Thank you.
Yes, sir.
So a lot of organizations are actually working for patients with cleft lip and palate abnormalities. One of them is CLAPA. So coming to the next case, this will be taken up by my colleague, Dr. Niharika.
Before you go to the next case, can I add something? Because I guess
Sure.
you didn't ask me a question.
Yeah.
So basically, if you are looking, and because there was so much discussion, so basically when you're looking about genetic causes, even prenatally or postnatally, it's very important to establish what kind of cleft lip or cleft palate you are seeing, whether it's a midline defect or whether it's a lateral defect. We were talking about syndromic and non-syndromic. In both of these, there are association of genetic disorders. And if we are looking at a genetic disorder, like the kid you showed, the kid also has dysmorphism. If you can go to the first picture, the kid also has hypertelorism. So in these cases, definitely there can be a genetic association. And before you even go to a surgery, you actually need to do a genetic testing, because even while anesthesia, the child might not come back. The child might also have cerebellar issues. So before surgery, especially in syndromic children, you definitely need to do a genetic testing. Prenatally, it can be a decision-making point, because if it is non-syndromic, as very nicely highlighted, that you can actually go ahead with repair procedures. But if we are looking at postnatally, and we are looking at a child with dysmorphisms, even before going into anything, you can first have a genetic assessment. You can first evaluate the child, what kind of defect it is. Not all defects are chromosomal. It can be an Opitz syndrome. It can also be a Kabuki. So understanding what kind of syndrome it is helps to manage the child postnatally also. And if it is non-syndromic, then you can actually assure the patients. Also, it's just not surgery and it ends there. Because if it is a syndromic child, you have to involve a multidisciplinary team, which might involve cardiology, neurology, nephrology. So before even going for a surgery, just because it's a cleft lip, you first need to rule everything out and then only plan the surgery. That would be my input.
So, very rightly said, for any birth defects, we have to rule out a genetic involvement in that. Definitely, how good that surgery is going to benefit or not. And especially isolated cleft lip, even with these organizations coming up, Smile organization, everyone, we have a very famous actor who has played the role of Joker, Joaquin Phoenix. He has a cleft lip and he chose to be like that. So there are a lot of couples, especially in UK, when I was working, they were like, they did not wanted to give the child in a minor way to give a surgical vote. That is completely up to the parents, and if they are completely normal and genetically fine with no syndromic association. So coming to the next case, we have a term baby being delivered at 40 weeks, and that baby had a was 3.5 kg. Apgar was fantastic. The mother is gravida too. Her first child is physically normal with the normal appropriate milestone. In this pregnancy, she had an anomaly scan, which was normal, no gross anomaly was detected. But in the third trimester, at 36 weeks and 4 days of gestation, the ultrasound showed a picture of 35 weeks 1 day, and it was noted that dysplastic bilateral short femur and humerus for the age. But the mother wanted a normal delivery, so we did a vaginal delivery, and both parents were of average height. There is no history of rhizomelic shortening in the limbs. The baby cried, and the anthropometric measurement showed that the head circumference is 36 and chest is 32, and but the upper body and the lower body were 30 and 15 centimeters. So with bilateral shortening of the upper and lower limbs with short fingers and a depressed nasal bridge, abdomen being protruded, the tone of the baby was normal, and this was how what the birth was looking at, and we X-ray showed this picture. So this is a case of definitely skeletal dysplasia. Dr. Deepanjali, would you like to throw some light on such a case of skeletal dysplasia and what of chondroplasia? Yeah, could you?
Yeah, so I'm Dr. Dipanjana. So, yes, so this what we are looking at, the head is longer, and the child, the picture you showed had sort of bowed, like rhizomelic shortening with bowing of the typical genu valgum which we see. So it is basically what we are looking at is achondroplasia. If we are sure it is an achondroplasia, we actually don't need to go for very difficult testing. There, 98% of the cases will have one mutation, which is the FGFR 1138G2C. And this FGFR 1138G2C is something which you can just look by Sanger sequencing. If that is not there, then it is basically a G2A mutation. And so most of these achondroplasias are due to de novo mutations, which means that the parents do not carry these genes, and this happens due to germline mutation. Normally, if the paternal age is on the higher side, we get achondroplasia. But in some cases, it might not be achondroplasia. It can be, like in this case, it's very, very definitely achondroplasia. But sometimes the syndromes might not exactly fit very nicely. In those cases, we would need a skeletal dysplasia panel. But if we are looking at a child who has these kind of who has this kind of mutation, mostly this is a single point mutation, the FGFR3 these mutation. If we do by Sanger sequencing, we get it, and we need to test the parents also, but most of the time this would be de novo. In very rare case, if the parents are carriers, like if parents are also affected, then we might get a very severe form of achondroplasia where children will be where it is basically lethal. Otherwise, achondroplasia is not lethal. Also, when we see a child like this, we need to involve the other faculties, and in this case we have to involve the endocrinologist, the orthopedic, and the pediatrician to work together and counsel the parents and move forward.
So like it's been discussed that it is basically a very simple test to do, but it's in very limited cases that we see, because most of them, they turn out to have a de novo or a spontaneous achondroplasia they have. And it is an autosomal dominant rate, with at least 50% of them passing down to the
50% only when one of the parent is affected.
One of the
It's
parents, if
mostly
it is
80% is de novo, yes.
Yeah, so So now, Dr. Varsha, how frequently can you diagnose it in, and I mean to say, how easily do you diagnose this antenatally, and what are the challenges you face as a radiologist to diagnose this?
Yeah, the presentations in skeletal dysplasias are after your mid trimester only, most of the times. So,
Yeah.
where we see short limbs, hands, hands, short fingers, a very large head, which is with frontal bossing, depressed nasal bridge, lumbar scoliosis, which is again very progressive through the course of pregnancy. There will be limb shortening, bowing of the femora will be there. There will be very small, rounded iliac bones, which are very difficult to see antenatally unless you do a 3D scan for it. Most of the
Right.
time, see it in an X-ray, which is taken postnatally. There is a very narrow thorax, which can be best seen in sagittal view only when you compare it with the abdomen and the chest together. When we see, when then we realize that okay, the chest is looking little more smaller than the abdomen. So these are the challenges. Like it's not very easy when it comes to the autosomal dominant variety of skeletal dysplasias, which are non-lethal type. So it is very important we go through the protocol, what we are doing through the scan. And if we find any little deviation from the normal, it becomes our responsibility to call them for follow-ups and keep screening them through the pregnancy, even in the third trimester.
So, Dr. Jayesh, would you like to add something on the diagnosing part? Other than being it difficult in third trimester, how often we do get short humerus, short femur sometimes, but how do you go ahead when you find a short femur? And how often are you encountering such a case?
Yes, short femur is associated with a lot of things.
Yeah.
First of all, we should look at the parents, what is their height. So whether it is a constitutionally short or not. Then uh, apart from skeletal dysplasia, Down syndrome is another condition where short femur is one of the marker, though it is not a very strong marker, but we should suspect it and we should go through the screening reports also. So short femur, then we should think of the skeletal dysplasia, and among the skeletal dysplasia, antenatally, we may not jump on the conclusive diagnosis, but at least we should try to differentiate whether it is a lethal skeletal dysplasia or non-lethal dysplasia. For that, apart from femur length, we should measure the length of all the long bones, whether all are short or only the femur are short. Then the chest diameter, shape of the chest, shape of the skull, vertebrae, the ossification, all these things, a number of fingers that we look for in all the skeletal dysplasias, and then conclusively we have to enumerate all the findings, and then we can partially come to a conclusion. One thing I would like to say that at 20-24 weeks scan, usually the non-lethal skeletal dysplasia, they have no features developed apart from slightly
That is
shorter
correct.
femur.
Yes,
So
yes, yes.
follow-up is required.
Dr. Raju, what is your take on doing an amniocentesis with such kind of ultrasound picture? And what would be the test of choice if we have such a patient? Dr. Raju, if you could
See,
help.
ultrasound actually, like Dr. Jayesh has mentioned, makes a good impression, and almost it's screening, but it's as good as diagnosis. But to those 30% where it could be chromosomally dependent, you may require to do an invasive technique here as well to see that there are no other abnormalities which can be there. So you have to do invasive prenatal diagnosis here as well in such situation. But what important point Dr. Jayesh mentioned, that constitutionally small baby. Now, other long bones, when you measure, then only you realize that this is not constitutionally small. Therefore, your insight should increase, and you should have a good imaging first, and then you should decide whether this patient, we have to do any invasive testing to confirm and make a diagnosis of a chromosomal problem. So counseling is very, very important when you find this situation, because it is not as simple as saying that, okay, there is a cleft lip and then we are going to handle it. This is a question of a sort of a lethal abnormality, and it doesn't compact with life so easily. So you have to counsel very well, and then you have to go ahead.
So I have a question by myself only. I have a doubt. Now that you have diagnosed it around, because you usually diagnose it in your third trimester or during a serial growth scan. So at around 26, 28 weeks, you find such kind of diagnosis, you'll do an invasive testing. And if now that you cannot terminate, I just want to know, you do an invasive testing, it turns out to have a positive test. What do you do at around 28 weeks plus? What do you do? Do you do an invasive testing?
Hey,
Or
I would counsel, and I
yeah.
would also involve
Yeah.
the other specialty of fetal medicine, the orthopedic, the neonatologist, and have a joint counseling and take this patient further, because doing an invasive, you may
Yeah.
even if you make a diagnosis, situation is not as simple as when you make
Yeah.
it before 24 weeks.
Yeah. So, Doctor
Invasive
Tripathi,
is not contraindicated at any gestational age.
no,
Whatever the
contraindication.
diagnosis,
No,
Yeah.
whatever the
Jayesh,
diagnosis we can give,
Yeah.
that we should try to give as early as possible. So better to
Can I
do
also
invasive
make
test.
Yeah.
can I also make a comment over here? So
Yeah,
there are
I wanted your opinion regarding if they come at third trimester. We have done a case. It is a positive diagnosis. We usually send it to the genetician. So, what is your part of counseling that you do in a third trimester fetuses in pregnancy?
See, with skeletal dysplasias, it's one part is easy, that we can first differentiate between a lethal one and a non-lethal one.
Yeah.
So
Okay.
if it is tending towards the lethal one, so obviously we don't obviously say about termination or etc., but we give them the knowledge basis that this child, even if delivered, might not do very well and might not make it. So, even before doing a genetic testing, they might wish to terminate, but we preserve the DNA. And with the DNA, we do the test so that we understand the recurrence in the subsequent pregnancy. That's one way to go for lethal skeletal dysplasias.
Okay.
Problem is if we are looking at non-lethal skeletal dysplasias, because these are the ones where the child will survive with certain issues.
Right.
Also, in this whole thing comes like when we are talking about lethal, non-lethal, we take the opinion of fetal medicine specialists to understand whether there is a problem in bone mineralization or not. So,
Okay.
because that bone mineralization also adds to what we are looking at, and then the family history. So, if we make a diagnosis over here, say even late, like then they have the choice right now with the PCPNDT Act being extended to take a decision later. Because if it is some milder form, like say I'm seeing osteogenesis imperfecta type 4, there is no reason to terminate because there are managements available, and it is still the choice of the parents, but they can have that choice. It's a knowledge base, they can have the choice. But if say I'm looking at something like osteogenesis imperfecta 2, or I'm looking at some more severe skeletal dysplasia syndromes, then in these cases, the parents have the choice to apply to the medical board and terminate their pregnancy. Not only that, they also know that about the recurrence, and they can plan their next pregnancy accordingly. So here diagnosis is extremely important. Say whenever they come, like they come late, they come early, depending on lethal, non-lethal, we can guide when the testing should be done, because if it's lethal, there is no point waiting for the reports to come in. But if it is non-lethal, then definitely we give the opportunity of the parents to understand what the diagnosis is, how far we can intervene, how far the interventions are available, and then they can take a call.
So, like you said, bone mineralization is very something that you asked. So, I'll ask Dr. Sarvesh, our fellow radiologist, and Dr. Varsha, what is your take on bone mineralization on an antenatal scan?
One comment can I make, Niharika?
Yeah, sure, please do. Go on.
If we are able to diagnose isolated dysplasia or isolated abnormality in only pelvic bones or in the femur, then like external rotation of the femur head or excessive external rotation, or there is a widening of the pubic symphysis more than the required distance, then one should also look into indirect anomalies which points towards the extrophy bladder, because that is one of the anomalies which is quite oftenly missed on antenatal diagnosis, because it may or may not cause any change in the amniotic fluid level. It can be a normal amniotic fluid level also, but it may not cause any oligo or excessive amniotic fluid as well. But that is a very morbid condition. Multiple surgeries, failures. Initially, the renal function is good, and so if it can be diagnosed because of the abnormality in the pelvic bone dysplasia, then it will be good. So I think that is another thing one could look for it.
One simple dictum for bladder extrophy is absent bladder with normal liquor, always suspect the bladder extrophy for
Yeah, but then
beginners in the
that's what
sonology.
recurrent ultrasounds required to be done, and one has to look for it. That is one comment I wanted to make.
Yeah, regarding hypomineralization, the hypomineralization of the skull and the spine should be looked for, and also the bones. So usually when there is hypomineralization, there might be associated, especially the skull and the spine, there might be associated skeletal dysplasia, the achondrogenesis, osteogenesis imperfecta, many other skeletal dysplasias will have this sort of hypomineralization. So it's very important we see the echogenicity of the bones as well when we are seeing the morphology.
Yes, I would like to add one more point. Even in radiology also we sometimes classify the abnormalities in skeletal dysplasia. Some skeletal dysplasia is causing increased density of the bones and some causing decreased density of the bones. So in a scenario where you have when you are dealing with a case of osteogenesis imperfecta, you will find that the bones are very brittle, and sometimes you'll see that even on ultrasound the echogenicity is increased.
Multiple
So
fractures can be there so many times.
fractures can be seen in such cases apart from the abnormalities.
No, so if we are doing antenatally, then a lot of information can come in. Like if we look at the vertebra, there can be the butterfly vertebra. There can be a lot of and like if we are doing when the child is born, like postnatally, there's a lot of things. Like a babygram can give us a lot of things if we are looking at just the skeletal dysplasia cases. Like very small things can lead us to a lot of syndromes. But prenatally, I don't think like everything is possible to look at. But there are pointers, and we go by those pointers, I guess.
Yeah. So, Dr. Raju, we have already discussed how we could have done this case by doing an amnio. What is your take on this non-invasive way of diagnosing fetal achondroplasia by doing?
Basically, achondroplasia, like the nomenclature is, it is not that there is no development of cartilage.
Yeah.
Issue is that it gets ossified, and therefore shortening takes place of all the bones, what you can talk about. So we have to detect this early. It is possible to detect this early, but not so easy because ossification may take little later. So a good follow-up scan and establishing the fact that this is going to be a short a fetus and it is achondroplasia. Mineralization issue is also very important to understand, because then you will come to know what is the prognosis of such a baby to be born. Therefore, a good counseling and making a good diagnosis, like what was mentioned, whether it is a lethal type of achondroplasia or non-lethal. Lethal could be handled in a different way. You could, you should not directly counsel overtly. You must inform the couple that this is what they are carrying. And if it is non-lethal, you have to have an association of the relevant specialists which are going to take over and take care of this baby when this baby is born. So you have to counsel in a proper way. You should not overtly counsel and make her take the decision to terminate. Neither you should not do it covertly. Otherwise, she will continue a pregnancy, and afterwards, postnatally, there are going to be many issues. And then you will have to explain why you didn't tell what could happen postnatally.
So, moving ahead, now that we are almost going out of time, how do you counsel the patient for the next pregnancy? What tests can be done? And can the next baby be disease-free? The most important question. I would like Dr. Veronica, what will be your outlook on such a patient as an obstetrician and an infertility specialist? If not, Dr. Veronica, can we have
I can take it, no
Dr.
issue.
Nidhi? Yeah, Dr. Jayesh, you can take it. Yeah.
Yeah. So first we have to establish the genetic diagnosis. Like in achondroplasia, Dr. Deepanjana said it is easy to diagnose, and once you confirm the genetic mutation, you should also test the parents. If one of the parent is a carrier, it is a autosomal dominant condition, and if parents are carrier, then invasive testing can be done at 11 to 13 weeks by Korean biopsy, and we can assure the child is disease free. But if it is a de novo mutation, then it is difficult to predict, and we cannot say about the chances of recurrence rate, but if parents wants a confirmatory diagnosis, I personally would go for a Korean biopsy if the mutation is
So,
known. What
yeah,
is your
just
take
to
in Deepanjana?
Yes, just to add over here, so normally if the parents are, they have now, FGFR3 is a gene which is 100% penetrant. There's no reduced penetrance. So parents, we can, by look, we can say whether they are having the gene or not. There's no, if it's osteogenesis imperfecta or CDP, X-linked CDP, those things are something that where we need a carrier testing. With achondroplasia, we normally wouldn't need a carrier testing because we can see, look at the parents, we can just do their height, head circumference, have a good skeletal survey clinically, and determine that. The second thing would be that even if this is a de novo, for all de novo mutations, we have to offer prenatal. This is because that there's something called the germline mosaicism. We cannot know what is there in the eggs and the sperms, and hence every pregnancy, if there is one pregnancy with achondroplasia, the recurrence risk is as low as 1%. But for every pregnancy, we have to order a prenatal diagnosis due to germline mosaicism. Just that we will not do a CVS. We will do an amniocentesis, because if we are looking at mosaics, then CVS can have that again 2-3% chance of confined placental mosaicism. So we don't normally recommend a CVS. We will recommend an amniocentesis, and from there we will take it. And in most of the cases, we can assure parents that this is 99% that they are going to have a baby which is absolutely normal, and only that 1% chance of germline mosaicism, which can lead to a recurrence of achondroplasia. If it is other skeletal dysplasia we are talking about, that also can be de novo. It can be autosomal dominant,
What test do we
autosomal
do?
recessive.
What test
Hello?
do we? Yeah. So what test do we do?
So if we have
Amniocentesis.
if we have identified the patient and it is autosomal recessive, in those cases we would go for CVS, because we need to give a reply earlier. But if it is de novo, then we can do an amniocentesis again. De novo again would have the same features as we are calling like the germline mosaicism. But if it is again autosomal dominant, then also we do a CVS. So anything which will have a chance of recurrence, we would offer a CVS, which is better. And because we are not concerned about germline mosaicism so much, and we need to give the reports better.
Yeah. So amnio followed by Sanger
CV.
or a yeah. Huh?
Yeah, when
Amnio
mutation is
followed
known,
by,
Sanger.
yeah, amnio if we have established a diagnosis, then amnio
Yes.
followed by the targeted gene testing. We really don't need to do like a bigger test or bigger panels.
Right. Okay.
Uh, when this is a autosomal dominant condition, achondroplasia. When both the couples are achondroplastic, then it should not be 100%, but it is 75% chances of recurrence. I had
If
come
both
across
the
one couple and the baby was normal.
Sir,
So,
if both the couple are achondroplasia, then you have to understand that there is if it's in one gene, right? So
Yeah.
there is about 50% chance that they will have a child with achondroplasia just inheriting one mutation. They will have 25% chance that they inherit both the mutation, and that child will be very severe. That's a severe form of achondroplasia, and that child might not live. That's lethal. And 25% chance that the
Was
child will
normal.
actually have absolutely no that the patient will have absolutely normal child. Yes.
So what is the take for the pre-genetic testing in such cases? Anyone can take this question, I think.
So this is a bit controversial. Like if it is a de novo mutation, we will do a prenatal testing. There is no doubt about it. But if parents are carriers, then we can
Yeah.
offer a PGTM. But see, PGTM, it's not as rosy as it seems. It's not something that like you do a PGTM and everything is fine. You have to understand, for PGTM we have to develop probes. And when we develop probes, the method by which we develop is called haplotype mapping, which means that there is one mutation, your concerned mutation, which you have picked up, and like surrounding it, there are small markers or small known sequences which we are also using, which are called the STRs, which are also used as a haplomap. So we have to, if the parents are carriers, we would need either the affected child, or we would need their parents, or which means the grandparents of the index child, to understand and develop these probes. Once these probes are made, if the probes are significant, sometimes we get dye blocks, we don't get good probes. But if we get good probes, then we can go for screening the embryos. Once we screen the embryos, we can take the good embryos and implant them. We have to counsel for failure of implantation even in those embryos. So if the implantation is successful, then also we need to offer them a prenatal diagnosis at 16 weeks, because the screening was done from the cryptotrophoblast cells, which were at which was a 5 days cryptotrophoblast cells. So we have to do a prenatal diagnosis at 16 weeks. That's mandatory, and that is the diagnostic test. Normally, the corroboration is 99%, and in that way they can have a disease-free baby.
Well, a very good point made, because PGTM, it is the profectoderm biopsy. It is not from the inner cell mass. And inner cell mass is not touched. So therefore, when you do a PGTM, by doing a trophectoderm biopsy, you have to first acquire that probe. And it is not so easy, also has been mentioned, to get those probes. You should know the mutation and have those probes to rule it out. And after doing that, also implantation of such embryos is at stake. Now we are advancing to the spent media technique. Spent media technique, and maybe a blastosynthesis biopsy. We are going towards that. But point is that you have to counsel these patients that after PGTM and implantation, yet they may deserve prenatal diagnosis by invasive technique to reassure, to reconfirm that they are carrying a pregnancy which is healthy, normal, and not affected. Even for that, suppose I know all this and I plan to do an early CVS at 10 weeks, 11 weeks, so that we have time to develop the probes, and pregnancy also has to be kept in watch, shouldn't advance too much. You have to have probes, even if you do a chorionic villus sampling at 10, 11 weeks by transabdominal or transcervical, whichever technique, then you have to still have the probes to rule out the mutation which were detected of the couple, of the parent, of the carrier.
But if we have done PGT, better to go for amniocentesis rather than CVS.
I know,
Right.
because of
If
mosaicism,
we are doing PGT, it's recommended for an amniocentesis.
amnio is recommended, but now also with advances, studying what is the percentage of mosaicism. If it is more than 50%, you have to discard such embryos.
Yeah.
If it's less than 50%, you have to go ahead with the
No,
transfer.
no. So that what you are talking about is aneuploidy. Here we are talking about a specific mutation.
Yeah,
So
correct,
for
correct. So you have
aneuploid
to have proofs.
embryos,
You have to have proofs for that.
anything which is below 30% has about 80 to 90% chance of implantation. Anything which is above 70%, we absolutely throw. Anything which is 30
Discard.
to 70, we have to counsel and implant. But what you are saying is aneuploidy, but
Yeah,
not for
yeah. So
PGT-M.
amniocentesis is what should be done in such cases. You're right.
So, secondly, it's not just the PGT-M, the whole process being difficult. It is the reproductive restrictions that we face as such, like doing an ovarian stimulation and puncturing because of the pelvic structural problem. So, we've talked our role regarding skeletal dysplasia. We have another question, but I think it's high time to wrap up. It's 1:30 plus, and I think we had a very fantastic panel, extremely devoted panelist we had, and I really want to thank everyone for participating in a very busy schedule. And all of us were actually involved in some other kind of webinar or CME on Birth Defect Day. So thank you so much, everyone, for participating. A very fantastically elaborated panel we had on 2 cases. Thank you so much.
Thank you.
Yeah. Okay. See you.
Thank you,
Thank you.
ISPAT. Thank you,
Yeah.
ISPAT, and my compliments to the moderator for taking out time and developing such fantastic cases, which we learned a lot from each other. Thank you so much.
Thank you,
So
sir.
thank you.
All
So
efforts.
thank you so much, Niharika and ISPAT team for taking us in this panel and in this so much informative talk. Thank you so much, Dr. Raju, for your such informative inputs. And we would definitely be very much in taking this into practice. Thank you so much, Deepanjita. And I think, Niharika, you were awesome. Thank you so much. Thank you. Thank you all.
We have such a wonderful panelist. Our surgeon, our genetician, and radiologist were absolutely fantastic. Thank you so much. We'll have a meeting again regarding some much more better
Okay.
topics.
Thank you.
Thank
Bye
you.
bye.
Thank you, Niharika. I enjoyed a lot.
Bye.
Bye. Thank
Yeah,
you.
I'm sure everybody will agree. This has been an amazing panel, which was beautifully conducted by Dr. Niharika Tyagi. Compliments to both the moderators for, bringing out such thought-provoking topics, I mean, today there's so much of a, what you call as gray zone. It's not totally black and white that if it's a trisomy 21, this is what the phenotype is, this is what the tests are. There are so many genes, so many conditions, so much more that we know today in genetics, and so many different technologies and tests that are available. You all have picked up some really fantastic cases. Compliments to both of you for that. Both the panels have been really engaging, and I'm really thankful to all the 4 moderators for the same. I'm thankful to the audience who have been so participative in this event, which has been hosted by ISPAT. Would we like to take any questions, Shreyanshi? Because I think
Yes, ma'am.
we have already exceeded our time. Is there any particular question that has been asked in the group chat?
Yeah, pasted it, ma'am.
Yeah, Dr. Niharika, could you get this question addressed, please?
There is a question from Dr. Sunita Katyanan. Can paternity be confirmed after the first missed period?
Paternity.
Paternity.
Yeah. So paternity testing, we all know, is carried on the genes. We have these genetic tests which look at 16, 24, 36 different markers. If you're saying after the first missed period, we need to wait till the time where we can get a chorionic villus sampling done with a sufficient amount of tissue. We need to rule out maternal contamination by doing something which is known as VNTRs, and although the villus is dissected very clearly and the maternal residua are removed, there still may be some maternal cells in that. So we rule that out by doing a VNTR testing. We take the mother's blood sample and the so-called disputed father. And by matching those through an algorithm, we are able to rule.
But actually, what is the legal status that we should know? Majority of the genetic labs, they do not do the paternity test, particularly assigned labs by court. They do it. So better we go through the court and then do the paternity test instead of doing paternity test on demand by the parents. That is what I know, but actually somebody may correct me if I am wrong. Madam Manjit, you are muted.
I'm sorry. You are absolutely right, sir. The reports that are acceptable in court are only those which are released by the forensic laboratories and which are collected in a police hospital and they follow the close chain of custody. Having said that, a lot of people are doing it for social reasons. And, they have to be told that this report is not legally acceptable. And that is the way the private labs are doing it. I think, we've digressed from our topic of birth defect. But yeah, genetics could have a lot of other queries by people. So, winding up this session, I would invite all the audience to engage with ISPAT. We have been around since more than 3 decades now. We are conducting a lot of academic activities. We are reaching out to the various parts of the country. Francie, if you could display the QR code. This is a way to become an ISPAT member. You could even go to the ISPAT website and the membership form is there. It's all online. You can just scan the code and then make the payment. Is just 4,250 rupees for a lifetime of membership. And this membership will give you access to all our academic activities, including our webinars, our PMEs, our newsletters. We are in the process of introducing a journal very soon. And we've got a lot of training programs in the pipeline. There's a roadshow coming up to commemorate World Down Syndrome Day, which we are proposing to do it. That falls on 21st of March. So become an ISPAT member and participate in this group for prenatal diagnosis and therapy. Once again, I thank everybody for participating, all the faculty, the moderators. I thank ClearNet team for being our AV partner. And thanks to all the audience for taking out the time on a Sunday to be around and to take part in this. Thank you very much.
Thank you.
Thank you.
Thank you so much, everyone, for giving us the opportunity to host the session. And we hope to have you again on our platform very soon. Thank you. Have a good day.
Thank
Thank
you.
you.
Good
Good
day.
day.
Thank you. Good day.